My name is Dr. Vikram Khosla. I'm an ophthalmologist based in Mozambique, and I'm working with the Norwegian Eye Health Project, and we cater eye health needs of poor patients from Mozambique. This patient, which I'm showing in this video, has primary open-angle glaucoma and advanced cataract. So I am using a Fugue's blade 300 micron tip to create a microtract filtration in the ciliary body or pars plicata region of the ciliary body. In other words, transciliary filtration procedure is done in this patient, and now I will start with the Phaco to remove this cataract. If you can see, I'm using 3mm knife to make the incision in the cornea, and then put some methyl cellulose in the anterior chamber, and also put some methyl cellulose onto the surface of the cornea to keep it wet. I use capsular access forceps to do the capsular access. First, a small nick is made in the central part of the capsule, and then capsule raised, and it's being removed in a circular manner. The size of the capsular access is around 5 to 6 millimeter diameter. Then a side port incision is made using 15-degree knife. Then hydrodissection cannula is inserted. I remove a little bit of viscoelastic, and then you can see the fluid wave going behind, separating the cortex from the capsule. And I'm pushing the nucleus, or just rotating the nucleus, in order to sever all the small adhesions between the cortex and the capsule. Then we start with the Phaco. I use primary chopping with a chopper and 0-degree tip. In Mozambique, I get a lot of hard cataracts, very advanced cataracts with advanced glaucoma. So I prefer this technique. So at one time you can at least control glaucoma as well as treat cataract. Since these patients live very far off, they will not come for follow-up. So I prefer this kind of surgical intervention in patients suffering from glaucoma as well as cataract. This microtract filtration has really revolutionized the care of patients with glaucoma. As you see, I have removed the nucleus, now the epinuclear complex I'm trying to remove. I use the same setting throughout the procedure, like pulse Phaco. Maximum power setting is 60. I keep the power setting at 60, and vacuum is about 300 millimeter of mercury. Now I'm using irrigation aspiration port to remove the remnants of cortex. A little bit of cortex is remaining in 12 o'clock position. I'm trying to remove that. So I use high vacuum 300 millimeter of mercury Phaco, and very little Phaco energy is used. Yes, now the irrigation aspiration is complete. I'll insert a little bit of methyl cellulose again to inflate the capsular bag, and then foldable implant. It's a tinted yellow colored pigmented IOL. Yes. Now this completes our surgery. I just wash out the methyl cellulose using irrigation aspiration cannula. And this patient recovered very good vision next morning. His pressure was 5 millimeter mercury and pre-op pressure was 40. So as you can see, just in one day it's dropped down to 5 millimeter. And I will discharge him after 2 days because he came from very far a place. So I will just keep him under observation for 2 days. Thanks.